Good afternoon, doctors, and welcome to Times Network India Health Summit 2025. Um, Liver transplant, very crucial topic in the health sector, and there's a lot of inputs, insightful thinking that we hope would come out from this discussion. So, without wasting time, we would just directly dive into a few questions that I have in mind, which all you guys can help answer. To begin with, doctors, there's this twin problem, which can be called like the twin A problem when it comes to liver transplant. I'm sorry. One is of affordability, the other is of accessibility. I'll start with you, sir. What, according to you, can be a feasible roadmap ahead to deal with these two challenges?
So first, speaking about affordability, almost everybody now everybody knows that a liver transplant usually costs something around 20 to 30 lakhs, right?
That's correct.
So what we can do is to affordability for even the general public, where it's required even in tier 2, tier 3 cities who doesn't have insurances or not a self-pay markets. So we can use the PMJ Yojanas as the base thing and top it up with the state-sponsored payments. Like you have seen in Maharashtra, they have topped up for the transplant package something around 20 to 22 lakhs is being paid by the government. So, same as well in Tamil Nadu also. So something like these things can help bridge this affordability gap.
Okay, so, and will this also help in extending the liver transplant program to the tier 2, tier 3 cities, doctor?
Uh, Thank you very much for having us here. To add to what Shashi has elaborated, I agree that the cost of liver transplant is around 20 to 30 lakhs, but it is a very dynamic pricing. All because it is about the indication of the transplant and the important medical condition. What is the medical condition of the patient at the time of transplant? If he is bit stable enough, if he has been referred in the right time from the primary care doctors, if the patient is fit enough, then actually the price comes down to even 15 lakhs. And so it's if they delay the treatment or the primary care physician has delayed in the referral or the patients ourselves because of false rumors and not fact checking, delay the need to seek medical attention at the right time, and they come to you in a much sicker condition, then you can even say 40 lakhs also. There's no limit to that. There's no ceiling limit to that. So that's where as a team we take important critical decisions and see, is this patient futile for transplant or is this patient fit for transplant? That is first thing. Because if the patient is fitter for transplant, no matter how much you spend, is not going to make it. So it's going to be unaffordable. But if your patient is fit enough, then you can actually cap the price. And if you have a strong team with a skilled manpower, good set of nurses and a supportive administration, actually that affordability comes down to even 15 lakhs, 18 lakhs also for doing living donors, liver transplants. And as Shashi has rightly said, the government sponsored schemes are there. Even in AP, CM Relief Fund schemes are there, where they give 10 lakhs and remaining we get in PMJ, and then the patient hardly spends 4 to 5 lakhs and they're actually getting a life-changing operation where they're going to have, and the AP state government is also giving pension for these patients post-transplant for procuring medicines.
So, what about donor availability? Isn't that restricting access for patients?
Yeah, and coming to the second part of accessibility, which you said, like in my hospital, in Kim's Hospital, we have 4 satellite centers in Andhra Pradesh, where, for example, we are conducting cadaver transplant program in a medical college in Srikakulam. It's a tier 3 city, tier 3 town, it's coastal town, where in the past 4 months we have done 12 transplants. In the first time in the country, 12 transplants have happened in just 4 months in a medical college. So with this hardly any infrastructure, but all patients are doing well. It's all because we follow this hub and spoke model, where the same central team offers the same kind of commitment and services to these 4 satellite centers, where our own patients are taken, hand holding is done, and made sure the patient is improved and comes back to Hyderabad after the transplant is done. So we are giving accessibility to Tier 2, Tier 3 cities as well. And coming to
Right.
the third part, which is a donor, so there is one living donor and there's one cadaver transplant. So cadaver means road traffic accident case, brain dead donations. When they do, as Dr. Abhidip pointed out, about organ donation drive. Because if everybody starts donating organs, actually we don't need to do living donor transplants. Otherwise, if somebody in the family, a family member donates a part of the liver, and that grows in the next 2 to 3 weeks' time. It's a normal physiology. That is living donor transplant.
Okay. So about when we talk about extending this program to tier 2, tier 3 cities, we do come across a strategy which is hub to spoke. If you could just elaborate on that strategy a little for our viewers.
Thank you for that insightful question. I come from a state which we can take pride that has the highest penetration of healthcare delivery across India. Because in Tamil Nadu, all the tertiary care is also being delivered at what you can say Tier 2 also. Tier 3 is also improving, but definitely there's only one Tier 1 which is Chennai. Tier 2 you can call Coimbatore, Madurai, Trichy and Erode. So all these cities have all the quaternary, including transplant. Already we have it. And Tier 3 is the next level of cities where there is some economy, there can be investment, but still there aren't any setups. But I am fortunate to work in a hospital which has helped us set up transplant programs in Tier 2 and even Tier 3. And when we go to the next levels, there are two models, which is one you mentioned about the hub and spoke. The hub remains from the Tier 1 cities, and the spoke can be multiple places. Because it is not just the infrastructure and resources alone. You can create that. There is investment that can come even in Tier 2 and Tier 3 cities also have money to invest in a hospital. But for a talent to come to Tier 2 or Tier 3 city is very challenging because ultimately as transplant surgeons, I would want to work in a setup where there is a significant volume of work. I can't be working in a Tier 3 city and doing 1 or 2 transplants a year. And if at all a Tier 3 city has to do a significant number of transplants, then that is where you need to have about affordability, because the population surrounding 250 kilometers around the Tier 3 city cannot be afford the high cost which of operating in the Tier 1 city. So by having the talent traveling from the hub to the spoke, definitely at least 25% of the cost can be reduced in the existing package, making it more affordable for the population of that place. Or to start with, we do what the satellite policy, which means we have a good physician or a surgeon in the satellite center who can screen patients, who can do a significant part of the evaluation there, and they just travel for the surgery, have their immediate recovery, and then go back for the follow-up. In this manner, the amount of time and the amount of expenditure that they will be spending in metro cities will be less. I think this will also be very helpful in providing facilities like transplant in Tier 2 and Tier 3.
Right. Thank you. That was really helpful, Doctor. Uh, that brings me to the next question. Since we have spoken so much about affordability, what do you think, Doctor, would be the role of insurance? We did speak about the government schemes as well, and CSR payouts to help people who are not as privileged to basically manage the cost factor in this liver transplant program.
So totally agree with whatever our panelists have said. It's at multiple levels. Importantly, transplant is still a bit expensive. I would say it's come down a lot from previous 10 years back. It used to be even more expensive. We've come down on cost. Importantly, that now people are understanding, and you have this hub and spoke model. Unfortunately, what happens, it is a very labor intensive and infrastructure heavy program, transplant, because you need a lot of instruments, you need ICUs which have to be decked up 24 hours monitoring with so much of resource, human resource. Now insurance till date, now few insurances have come forward who actually cover for these people, but it's still like, a lot of insurances when a patient's form goes saying that needs a transplant, they deny the insurance. So I think awareness, which is very important in healthcare sector, in public, and even in insurances, that it's not only because the stigma of transplant, in liver transplant specifically, if you ask somebody needs a transplant, they will associate it with alcohol, which is very common. So what they would say, rejected. We see most of the patients nowadays who get transplanted for fatty liver, which we call fatty liver NASH. There are newer definitions now, but even in females they reject the insurances. The CSR that you spoke about is very, very important, but unfortunately the CSRs, all the big companies, the corporates have only limited access, which they have limited to the pediatric age group. So only for kids they do sponsor, not for the adults. And you see, like, the ratio of adult to pediatric transplant would be 90 to 10% or even lower if you look at that. So finance is a big challenge. Insurances have to incorporate, do their due diligence, and actually get these people and start covering for transplants as well, which we are actually suffering. Which it's a very pertinent question in today's time. Now, few insurances have come up with a clause of organ transplant, but still they do not cover. There is a cap there, so they have to actually give a clause as organ transplant as a donor and a recipient, which should be covered, which is still not happening by the way.
Any government scheme, sir, that that's
Yes, there is
in
government
place?
schemes. All governments have something. Tamil Nadu and Andhra Pradesh have
These
it.
are state government
State government,
specific
yes.
schemes. Any central scheme that
government actually, Arogyasri still does not cover, but through the center, states have started paying out some. Some states have lucrative insurances, but some have substantial only for BPL card holder. That is the below poverty line, but not for everyone, because a middle class any day is not easy to afford a transplant. So
That is true.
They have to actually look beyond the below poverty line, and also maybe incorporate it for middle class or lower middle class who can actually, because transplant is now required very often in people, and we see for financial need they can't get a transplant.
Yeah, which is why my question, because we do feel the need when we look around. We do feel the need for more such schemes, whether be it central government schemes or state government schemes, so that those who are not privileged enough can be helped. Thank you so much for the answer, sir. Uh, my last question would be on a discussion. Actually, it's not a question; it's a discussion. See, we look at liver transplant as like a lifesaver program, but we also would agree that there's a need to shift focus from lifesaver to making this program more sustainable and accessible. So, how do you think this shift can come about? And I'm sure it's not going to come about in a fortnight, but there has to be a way forward.
As you said, any transplant is life-saving. People will not have transplant till the time they have medical hope. Till the time they feel that a disease can be medically cured, they would not go for surgery. Unfortunately, for liver and kidney, patients would opt for transplant only when they are quite late in their clinical spectrum. Good thing with kidney is that they have a dialysis as a bridging. Liver, we do not have a bridging. So most of the transplants done now are usually either acute failure or even in chronic cases, late transplants. So they become life-saving. So this is the reality today. What should be done is awareness both for the patients, for the physicians, for the doctors, community, everybody, that this is a disease which will progress to a point. Medical treatment has limitations, and beyond a point, you should opt for this surgery. If you opt for this surgery well within time, when you meet the criteria, then your cost would be less, the complications would be less, and awareness would be. So right now, as you said, most of the liver transplants are actually life-saving. Somebody has had sudden liver failure, they would come for transplant. Somebody who is on a liver disease medical treatment for 3 years, 5 years, 7 years, the physicians would tell them to have transplant, still they would go on with medical treatment because that's the normal psychology. One, the cost is high. Even if the cost is, say, less, people are afraid of getting the operation. Then the important concept of donors. Somebody, they have to find a donor. So right now medicine is life-saving, less elective, but it can be made more elective. Elective in the sense that once they meet the criteria, you don't go and do transplant on patients who are very early in their disease. So once they meet the criteria, then they should not waste time deciding about the transplant. So this is one, and it will come through multiple methods, which I said. It will come through awareness among the patient that they know they have a disease which does not have a medical cure, they would need surgery. More awareness amongst us physicians to refer them and tell them about transplant. Third thing is the cost will come down, they would be easy for them to decide. Fourth thing is the donor availability. Many, we are having transplant in the country for more than 20 years. The costs have come down from 20 years to now. It started with 20-25 lakhs and still many centers will do it below 20 lakhs. So the costs have not gone up. The main problem right now is the availability of donors. We have group specific. So once these things are taken care of, probably people will accept their disease more. They would come early and they would not come at the last minute, which would be good for us, for them.
If I can add something here,
Yeah,
what you
sure.
said,
Sure.
very pertinent point is how many treatments do you know that costs have come down? Because most of the treatments that happen, the costs eventually have gone up. But with volume happening, the costs have come down. So that is what we are talking like, liver transplant, we do glorify it a lot, saying that and that perception goes to the patient's mind that I'm going for something which is supernatural or unnatural. But I think we should actually make it so common in public's mind that if you need a transplant, earlier the better, because that helps everyone, which is everybody's talking about it. I think that's what should go to the public directly. Like, if somebody knows has a heart disease, should go to a cardiologist.
So prevention is
Prevention,
cure is the
yes.
first step.
I'd like to add one point, very often overlooked is I think transplant will be a successful treatment only if public sector hospitals take up transplant more frequently. Because for an agricultural laborer, even if the government is ready to pay for his surgery in a private hospital,
What is the ratio right now, sir?
there are hardly 2 or 3 public sector hospitals in the entire country will be doing transplants. Because it is not just about making it affordable and accessible for the population alone, even the process of donation. So if people today think that transplant is done only in private hospitals and they do it for patients who have money, they sell the organs and these things. But when organs are being donated to people in need in public sector hospitals also, I think the donation will also go up because the trust in the public trust in the system will be higher, because they will know that ultimately everybody is benefited, and not just the man with money in a private hospital. So it is important that the government make sure that public sector hospitals take up transplant programs seriously and make it a reality.
Right.
And to add to the points, I think we should also give impetus to the organ donation drive. So it should become a people's movement. So where, just like how Swachh Bharat or Vocal for Local, all these movements, Fit India, like that, even organ donation drive also should be taken on a national scale. Then we can also, if government can bring up some legislations like, if you pledge your organs only, you will be eligible for social security benefits, like how it is in abroad. In that scenario, I don't think we'll be actually waiting for the donor availability, as that's the most important question. And automatically the cost will come down because patient doesn't need to wait for ages till the organ is allocated, and so accessibility also increase and patient awareness also gets better. So that is something where the government should look into.
Right. This has been really insightful, and if I had it on me, I think I would have loved to continue it for a little longer, but we're really running short of time. But before I let all you doctors go, one quick question and just a quick pointers from each of you. What will it take for India to, let's say in 5 years, to build a liver transplant program that can balance cost, accessibility and sustainability? Just one quick, one each from all you guys.
For me, the first thing would be donor awareness. Currently, I'll just give some numbers. Currently, we are at a 0.8 donations per million population. Even if we reach 2 to 3% of that, 2 to 3 per million population, many of the transplants, the availability, that gap in the availability of organs will be coming down significantly.
I think it's also you need to have a strong DNA. Doctors, nurses, and administration.
That's a good one. I'll carry it forward.
So the other important thing is today liver transplant is not rocket science. It's a very well established procedure with very good safety margins, and training can be done in India itself. So a lot of the cost limitation that we have is because of the perfusion fluid that we use is costly because not made in India. The monitors, some of the monitors we use are hugely expensive, 25 lakhs, one single monitor, because they are not made in India. The sutures, initially when we were using, but they were not made in India. So with the technology now available, if we start making everything locally and bring down the infrastructural and resource cost significantly, we must be able to provide it in a much better way.
Prevent as long as you can, transplant as early as you can once they need a transplant. I think that will save a lot of things.
My take are almost the same. Just two things. One, better donor availability. So the cadaver program should increase a lot. A person who has a disease does not have this tension of finding a donor will solve many of the problems. And surgically, as surgeons, we all know that doing a cadaveric transplant is surgically simpler compared to a living donor transplant. So one point is if we can increase the donor, especially diseased donor, the transplant can penetrate to deep into the country. Second thing is, rather than thinking of reducing the cost, because as was mentioned, there is a limit to what cost can be reduced. A utopian scenario is which will happen over the time that all the instruments and all those things come down. So there is a limit to what cost reduction can be done. It's not that today if the transplants are done at 17, 18 or 19 lakhs or 20 lakhs, the hospital makes 15 lakhs out of it. So the cost is high because the treatment is complex. So the cost will not come down. How to subsidize this cost becomes more important. If you look at costs in UK, in US, in Indian rupees, it would be 1 crore or 2 crore plus.
Valid
But then
point,
it
yes.
has to be through insurance, it has to be through government incentives, it has to be through corporate social funds, so that patients, how do you select those patients, what criteria is different. So for me, two takes: reduce the cost not by squeezing the hospitals because they can't do it, do the financial sourcing of the patient, and go for cadaveric donation so that the donor problem is over.
Thank you so much, doctors. With this, we come to an end of this very insightful discussion. Thank you.
Thank you. Thank you.